In this video, we will identify indications for taking vital signs and assessing pain, describe nursing responsibilities in assessing vital signs, demonstrate how to record and report vital sign measurements, and identify the elements of pain assessment. Vital signs. 5 standard indicators providing clues about health status: temperature, pulse, respiration, blood pressure, and pain.
Vital signs are usually assessed as the first step in the nurse's interaction with the client. An initial assessment establishes the client's baseline status. Repeated assessments monitor for changes. The frequency with which you measure vital signs will depend both on the physical condition of the client and your facility's policies. A change in one or more vital signs can point to a change in the client's health status and to the types of follow-up assessment needed. When assessing vital signs, keep in mind the following. Prior to assessing vital signs, review the client's medications, as many medications can alter the signs and lead to false results. Always compare the current finding to the client's baseline. Assess findings within the context of the client's age, because age often influences the normal range of values. When encountering an abnormal value, measure again to validate your findings, keeping in mind that what is normal for one client may be abnormal for another. Then perform the appropriate follow-up examinations to assess for other signs and symptoms. Measure temperature first. This will usually help relax the client, and that's important because activity and anxiety can render the other vital signs inaccurate.
Depending on the measurement method, normal body temperature ranges from 35.9 to 38 degrees Celsius or 96.7 to 100.5 degrees Fahrenheit. Rectal, temporal artery, and tympanic membrane temperatures are slightly higher than oral temperatures. Axillary temperatures are slightly lower.
To ensure accurate data recording, correlate your measurement with the client's physical activity, age, gender, and state of health, and the time of day. Temperature may be measured using any of several devices. Electronic readings are fast and convenient. To decrease the risk of infection, use disposable single-use tips or covers, or employ a disposable thermometer. Make sure to clean electronic sensors with an alcohol wipe after each use. To prepare for taking an oral temperature, first make sure the client has had nothing cold or hot to eat or drink and has not smoked or chewed gum for the past half hour. If using an electronic thermometer, turn it on, making sure the battery is fully charged. If using a glass thermometer, shake it down to move the contents below the level of 35.5 degrees Celsius or 96 degrees Fahrenheit. Cover the tip of the probe. Next, place the thermometer in the sublingual area of the base of the tongue, either to the right or the left of the frenulum.
Open your mouth, please. Did you keep your lips tightly closed and breathe through your nose, please? Did you open your mouth, please?
Carefully note the reading and record it immediately. Dispose of the used cover. When measuring axillary temperatures, prepare your thermometer the same way as when taking an oral measurement. Place the thermometer in the axillary fold.
Hold this firmly against your side. This should only take a few moments.
Axillary temperatures are considered the least accurate, so to confirm suspect findings, recheck using another method. When measuring temperature using a temporal thermometer, move the sensor slowly from the center line of the client's forehead across to the top of the ear. Continue to a point behind the ear, taking care to remain in continuous contact with the skin. When using a tympanic thermometer, first place a disposable cover on the tip. Pull the client's pinna up and back to provide access to the ear canal. Angling the device towards the client's jaw, insert the tip gently into the ear canal, taking care to avoid occluding the canal. While rectal temperatures are considered the most accurate, this method should be used only if other methods are not practical. If using a glass rectal thermometer, prepare it by shaking it down. Apply the appropriate cover, then lubricate it. Insert the probe into the client's rectum. For adults, about 2 to 3 centimeters or 1 inch. Hold the device in place until the device beeps. Use a tissue to remove remaining lubricant from the client, then see to his comfort. Dispose of the cover, then note your reading.
Pulse is usually assessed by palpating the radial pulse point, one of 9 pulse points. Other pulse points include the ulnar, the brachial, the apical, the femoral, the dorsalis pedis, the posterior tibial, the popliteal, and the carotid.
When palpating the pulse, note its rate, which is the number of beats per minute.
In adults, the normal rate is 60 to 100 beats per minute.
Also note the pulse's rhythm, which is the interval between pulses. Rhythm is usually described as regular or irregular. Note amplitude, which is the force of the pulse. You judge amplitude by noting how much pressure you must exert on the pulse site before you can no longer feel it. Express your findings as 1+, meaning weak and easily subdued, 2+, meaning normal, or 3+, meaning that the pulse is very strong and difficult to subdue. Note elasticity. Normally, the artery should feel smooth and resilient. Abnormal findings include nodular or stiff. While looking at the second hand of your watch, assess the radial pulse by pressing the site with the pads of your index and middle fingers together. Take care not to press so hard that you obliterate the pulse. If the pulse rhythm is regular, count the pulse beats for 30 seconds, starting with 0, then multiply the number of beats by 2 to obtain the beats per minute. If establishing a baseline reading, assess for a full minute. If the pulse rhythm is irregular, further assessment is called for. For instance, seek assistance from a colleague to auscultate the apical pulse simultaneously with the radial pulse to assess for a pulse deficit.
Respiration is breathing. One respiration represents one inspiration and one expiration.
During your session, and without the client's awareness, observe the client's respiration. For example, make your observations while appearing to continue your assessment of the pulse. Assess the rate of respiration, or breaths per minute. Count respirations using a method like that used with the pulse, counting for 30 seconds and multiplying the number by 2 to obtain the breaths per minute.
A normal respiratory rate is between 12 and 20 breaths per minute.
Assess for rhythm, which is the interval between breaths. Rhythm is usually described as regular or irregular. Note depth, whether the respiration is shallow, moderate, which is normal, or deep. Assess for effort, using diaphragm and intercostal muscles, which is normal, versus accessory muscles. Assess for noisy breathing. Normal respiration, called eupnea, is relaxed, smooth, effortless, and silent. Respiration changes with the demands of the body. Ask about factors such as exercise, anxiety, pain, and smoking.
I take a 2-mile walk every morning with my friends.
Also, observe the client's posture and review medications and medical history.
Blood pressure. The force exerted on arterial walls by the passage of blood. Blood pressure, also referred to as BP, is measured and expressed as systolic blood pressure over diastolic blood pressure. Normal systolic readings range from 100 to 120. Normal diastolic readings range from 60 to 80. Variations result from many factors, including age, gender, weight, stress, medications, and ethnicity.
Measure blood pressure using a stethoscope and a sphygmomanometer. The sphygmomanometer consists of a cuff, an inflator bulb and hose, and a gauge. To avoid inaccurate readings, be sure to use the correct size cuff for your client. Make sure the client is calm and relaxed. The client should avoid eating, smoking, or exercising for 1/2 hour beforehand. To establish a baseline, measure both arms and compare. Record the higher of the two values. The client may be lying down or sitting with legs uncrossed. If sitting, the client should not slump. Make sure the client's arm is exposed and take care to avoid constricting it. Support the arm at heart level, slightly flexed and with the client's palm upward. Center the cuff about 2.5 centimeters or 1 inch above the brachial artery, midway between the elbow and shoulder. Most cuffs display an indicator line to assist in cuff placement. Align the indicator with the artery. Fasten the cuff snugly around the arm, leaving a 1-inch clearance above the antecubital area to allow placement of the diaphragm of the stethoscope. While palpating the brachial or radial artery, inflate the cuff by pumping the inflator bulb until the pulsation disappears. Immediately note the reading on the gauge. Then continue to inflate the cuff to 20 millimeters of mercury above the point where the pulsation disappeared. Next, while continuing to palpate the artery, open the bulb valve just enough to slowly deflate the cuff. As soon as you again feel a pulse, note the reading on the gauge. This is your estimated systolic BP, also called the palpable systolic pressure. Then quickly deflate the cuff completely. Next, obtain the diastolic BP. Wait 15 to 30 seconds to reinflate the cuff to allow blood trapped in the veins to dissipate. Insert the stethoscope into your ears. Place the diaphragm of the stethoscope lightly over the brachial artery. You will not hear a pulse until the cuff is inflated. Keeping your eyes on the gauge, quickly inflate the cuff to 20 to 30 millimeters of mercury above the estimated systolic BP. Slowly deflate the cuff at a rate of about 2 to 3 millimeters of mercury per second as you listen for pulse sounds. You will hear the first Korotkov sound when the gauge coincides with the client's systolic BP. Continue deflating the cuff, noting the point when the last pulse sound disappears. Read the gauge. That point defines the client's diastolic BP. Record the BP. Also record the client's position, which arm was used, and the cuff size, particularly if non-standard. Pain is thought of as the fifth vital sign because, like the 4 measurable vital signs, it too is an important indicator of health. Unlike the other vital signs, which can be measured objectively, pain must be assessed by obtaining subjective data.
Could you describe what the pain feels like?
Yeah, it's a continuous ache. It's not a sharp pain.
On a scale of 0 to 10, 0 being no pain at all, and 10 being the worst pain you've ever felt, how would you rate it?
I'd rate it a 4, but sometimes it goes up to a 6.
Okay. Where is your pain? Can you point to it?
Yeah, it's like right through here and on the back of my shoulder.
Your shoulder. Okay. So, does it radiate anywhere?
It often extends all the way down my arm.
Is there anything that makes it better or anything that makes it worse?
I guess if I lift my arm, it makes it worse. If I keep my arm relaxed and supported, it hurts less.
A 0 to 10 pain scale rating is standard in assessing pain, but other scales have been developed, such as the FACES scale, that can be used in children or in adult patients with literacy or communication difficulties.
Document your findings using the client's own words whenever possible. The 5 vital signs are extremely important indicators of a client's health status, and abnormal findings indicate a problem in one or more body systems. Become familiar with the methods and equipment for measuring vital signs. Thermometers, peripheral pulse palpation, counting respirations, using the stethoscope and sphygmomanometer to measure blood pressure, and pain assessment, in which you gather subjective data using therapeutic communication methods. Measuring vital signs is usually the first step in assessing clients. By establishing baseline measurements early and following up with repeated assessments, you will be able to differentiate between normal and abnormal results, leading to timely and effective health care for your clients.